Today is going to talk about approach to bicarbonate and lactate in diabetic emergencies. As you know, both the DKA and HHS, that is hyperosmolar hyperglycemic state, have distinctly different presentations of lactate and bicarbonate. Both of them have got diagnostic values, but though we have very low serum bicarb in DKA, it is not so in HHS. And though we have an elevated lactate in DKA, in HHS, it comes only in certain specific situations like hyperperfusion. To know more about it, let us go on to the speaker, Dr. Balaji Venkatachalam.
Good evening. I thank Dr. Ranjit and other organizers for this wonderful opportunity. So quickly going into the topic, I'm going to focus on how the bicarbonate should be handled and how lactic acidosis should be handled in the context of DKA. So over the next 15 minutes, maybe with the 18 slides, I'll be talking the practical aspects, how to handle these molecules. I hope my voice is clear. Is it audible?
Yes, it's very clear.
Next slide, please. So when it comes to indications for bicarbonate, the indications are pretty straightforward. Next slide, please. First, before going into the indications, we need to understand why acidosis should be treated. Mild to moderate acidosis, the homeostasis itself will take care. As long as you hydrate the patient, the homeostasis will take care of mild to moderate acidosis. We need not do anything separate. On the other hand, when somebody has a severe acidosis, you can see that the contractility comes down. There will be severe LV dysfunction. Takotsubo cardiomyopathy, one of the causes includes severe acidosis. And both your insulin and catecholamine won't work. You will have catecholamine resistance and insulin resistance. You'll be keep giving insulin infusion, it won't work. You'll be giving vasopressors, the mean arterial pressure will not be maintained. And of course, it will bring a lot of arrhythmias because of potassium especially, and also phosphate abnormalities. And your hemodynamic instability will worsen. So these are the downside of having a severe acidosis in the patient. That's where you need to intervene. Next slide, please. The flip side of IV bicarbonate. See why IV bicarbonate just like that should not be given, because it is a very toxic molecule. Especially the cerebral edema risk is going to be very high. So there are certain risk factors why a patient gets cerebral edema because of IV bicarbonate. When the PCO2 is very low, especially when it is less than 15, 14, 12, then the risk of cerebral edema is very high. And when the urea levels are very high, when the pre-renal urea levels are very high, that signifies severe volume contraction. When you give a hyperosmolar molecule to a volume contracted individual, it will worsen the shock. That is one thing. And also insulin bolus. That's why we are moving away from insulin bolus in DKA. When you give insulin bolus, rapid osmotic shifts can happen. The most offending molecule will be sodium. When you give insulin bolus, sodium shifts happen. That will also worsen the cerebral edema. And this risk is more in thin young individuals and children. We don't see in obese type 2 diabetic patients. We see more often in either in thin young individuals, type 1 or type 2, or children, type 1 or type 2. This is where cerebral edema risk is more. And there are other complications like rebound acidosis, because you will give one bolus of bicarbonate, you will not do the correcting, you will not do anything for the correct precipitating factors. Like you have to correct the dehydration, infection parallelly. If you don't do that, rebound acidosis can happen. Paradoxical CSF acidosis, hypokalemia, hypernatremia. It's a sodium overload, rapid sodium overload, which can lead to even pulmonary edema. Next slide, please. The consensus opinion whether to give bicarbonate or not is based on 3 old trials. No modern trials are available. It dates back to 2009 and before. Maybe one trial came in 2011. They are all predominantly low quality observational studies. No proper RCTs are available for bicarbonate, for a simple reason being will not be able to do RCT in a sick, hemodynamically unstable patient. So the consensus opinion is don't give bicarbonate unless the pH is less than 6.9. This is reflected in the Harrison's Principles of Internal Medicine also. You can see the trial also in the book. pH less than 6.9, you may consider IV bicarbonate. Next slide, please. On the other hand, you can also consider IV bicarbonate in special situations like when the patient is very drowsy with severe acidosis. And if the eGFR is less than 30, you can consider a bicarbonate. Whether to give bolus or an infusion is always debated. And again, we don't have a high quality evidence to recommend whether bolus is needed or infusion is needed. Generally, most clinicians in the peri-arrest situation, they give a bolus followed by an infusion. I will not be able to say whether this approach is right or wrong because there is no high quality consensus on this. But generally, when the eGFR is less than 30 with severe metabolic acidosis, high sugars, you can consider IV bicarbonate. Do not give bicarbonate just to taper vasopressors. This is the point I need to tell. Just because somebody is on high dose vasopressors, don't give bolus bicarbonate. Next slide, please. As it previously mentioned rightly, the quantum of acidosis will be very severe in DKA than hyperosmolar coma. Though the sugars look very alarming in hyperosmolar coma, just when you start hydration, the sugars you'll be surprised to see that sugars come down quickly just with simple hydration in hyperosmolar coma. On the other hand, in DKA, dehydration will also be profound, acidosis will also be profound. You will need fluids, you will also need insulin infusion. That's why that's a practical difference. So in our clinical practice, we see more need for IV bicarbonate in DKA than hyperosmolar coma because in hyperosmolar, a simple hydration itself can solve the problem. So when it comes to lactic acidosis, lactic acid is it's quite controversial and an interesting molecule and probably a wrongly understood molecule for a very long time. And it is one of the causes for HAGMA, high anion gap metabolic acidosis. The three major causes for HAGMA, high anion gap metabolic acidosis in clinical practice include DKA, lactic acidosis, and uremic acidosis, and other causes like your ethanol, ethylene glycol can also. Let's say it's a different entity. As such, you may not have a standalone lactic acid in a DKA. Lactic acids can be normal. If you see a high lactic acid in the background of a DKA, you have to rule out other contributory causes. That's the point I need to tell. Because it is a product of anaerobic glycolysis. Rarely, aerobic glycolysis can also increase your lactic acid production. And you know that there are causes. Broadly, the lactic acidosis causes are divided into two types, type A and B, where type A, the production is more. In type B, the clearance is less. Predominantly, whenever there is a reduction in oxygen delivery, for example, cellulitis, necrotizing fasciitis, or limb trauma, limb arterial insufficiency, type A lactic acidosis occur. On the other hand, whenever there is an altered metabolism, including reduced hepatic clearance, type B lactic acidosis occur. And your metformin also predominantly falls into type B lactic acidosis. This accumulation leads to lactic acidosis. The point I want to drive here is lactic acidosis is just a risk indicator. It is not a risk factor. It is just a risk indicator. When you see a high lactate, for example, 5, something like that, there is something wrong, fundamentally wrong with the patient. It is not a risk factor. Just for you to compare, hyperglycemia is a risk factor as well as risk indicator. If you see a sugar of 400, that means patient may have an underlying sepsis. That also means patient is going to have high mortality because hyperglycemia is going to kill patients as well as it is a risk indicator. On the other hand, lactic acid is just a risk indicator. It is not a risk factor. He is not going to die because of lactic acid. He is not, I again stress this point, he is not going to die because of lactic acid. Rather, high lactic acid says something is fundamentally wrong with the patient. For you to understand this, I keep telling this analogy to my students. See, when a murder happens in a particular area, for example, in T Nagar or Saligramam, murder happens, you will investigate who came to that place. When you take up murders which happened in the last 1 year in a particular area, if you keep seeing who came to that place more commonly, more often, it will be police. Cannot say that the police are the reason. Police personnel, they are the responsible for murders. Rather, they were there to investigate like that. Lactic acid is a consequence. It is not the etiology. So when the lactic acid is high, you should find out what is the fundamental problem, do something about that. Just bringing down lactic acidosis won't solve the issue. It's not because it is a risk indicator. Next slide, please. The normal range, can be up to 2. Next slide, please, Ranjit. So when the levels cross 2, we keep saying that lactic acidosis is there. When the levels are more than 5, we say that severe lactic acidosis. We brand it as severe lactic acidosis. Next slide. So if you see the tissues producing excess lactate at rest, you'll be surprised to see skin contributes the maximum lactic acid, almost equal to muscle. At rest, your skin contributes to maximum lactic acid. On the other hand, when somebody is heavily exercising, it will be skeletal muscle. Pregnancy, your normal placenta can also produce lactic acid, and when it crosses even beyond the normal level, even traces increase, it can pass to the fetus as well. And fetus has its own in situ mechanism to handle the lactic acid. Beyond a point, during pregnancy, when lactate levels increase, it can cross the placenta and affect the fetus. And ARDS, an infected lung, can be an independent cause for lactic acidosis. Next slide, please. If you see, when it comes to metabolism and elimination, liver handles 60% of the lactate elimination. And of course, kidney also handles 30%. Lactate is a normal fuel for the heart for ATP protection. So, lactate is also needed. Complete elimination of lactic acid, you are negating the fuel for the heart. And lactate is also a source for glucose, gluconeogenesis. It enters into citric acid cycle. That's how lactate is handled. So we have projected as if lactate is a villain. Rather, lactate also is useful in gluconeogenesis. It is also a fuel to the heart. Next slide, please. So how do you take the lactate samples? Venous samples are as good as arterial samples. No need to prick an artery to take a lactate sample. Between BBG and ABG, your pH, your PCO2, your bicarbonate and lactate are same. So I'll repeat, your pH, PCO2, bicarbonate and lactate are almost same between a venous sample and arterial sample. You take an arterial sample only for two reasons, for to check the PO2 or to check the saturation. Otherwise, a venous sample is as good as an arterial sample. And you have to instruct the nurse not to apply tourniquet for a prolonged time, more than 20 seconds. That itself can elevate lactate levels. So quickly the lactate levels can go up for the prolonged tourniquet. And you have to send it to the lab immediately within 15 minutes with ice. Otherwise, it can be a false elevation from the lysis. Next slide, please. So how to manage lactate? Diagnose and treat the underlying condition. So don't try to just do dialysis and remove the lactate. Of course, dialysis will be needed if there is a coexisting metabolic acidosis, but rather just by doing dialysis, for example, somebody has a necrotizing fasciitis, AKA, and hyperlactemia. Just by doing dialysis, you will treat the acidosis, but unless you give antibiotics, unless you do surgical debridement, unless you control the sugars, the lactate levels are not going to come down. It's going to kill the patient. That's why though the lactate level comes down with dialysis, unless you treat the primary medical condition, the patient is not going to survive. There is something called lactate gap. Next slide, please. Lactate gap, like how we tell saturation gap, how we tell anion gap, delta gap. There is something called lactate gap. Lactate gap, because you measure lactate by two methods, your oxidase method and your dehydrogenase method. The assay methodology can differ, and your point of care analysis, including your radiometer 700, which is the commonest ABG machine used in most of the hospitals, cannot distinguish between lactate and glycolate. Ethylene glycol toxicity can also a reason for glycolate levels elevated, and your conventional ABG machines won't be able to differentiate between the two. So keep this in mind. When apparently lactate is normal, but patient has a severe metabolic acidosis, unexplained, think of lactate gap. That is a shrewd clinician has to think of lactate gap. Next slide, please. So there is something called D-lactate, dextroisomer. Your conventional ABG machines or your lab assays measure only the levoisomer. Your dextroisomer of lactate is missed. That is a rare cause of HAGMA, high anion gap metabolic acidosis. Because you have to suspect D-lactate levels whenever you see normal glucose, normal L-lactate, normal urea creatine levels, normal LFT, but HAGMA is high. Patient denies alcohol intake. I'll again repeat this. Glucose levels are normal, L-lactate levels are normal, urea creatine normal, LFT normal. He denies alcohol intake, but high HAGMA, high anion gap acidosis, think of D-lactate because it will be missed by your conventional ABG machine. The patient can present with cerebellar symptoms, altered sensorium, slurred speech, and ataxia. Can somebody tell what is the commonest cause of D-lactate levels in the modern era? What is the commonest cause of D-lactate elevation in the modern era? Any guess? It's post-bariatric surgery. Post-bariatric surgery, immediate post-operative period, because you may remove the bowels. And of course, the conventional causes include short bowel syndromes, both medical and surgical causes for short bowel syndrome. When you do an extensive small intestinal resection, or medical causes of bowel failure, including celiac disease, inflammatory bowel disease like Crohn's disease, ulcerative colitis, jejunal bypass. Somebody is on high carbohydrate diet, and probiotics are also blamed for D-lactate levels. So keep this in mind when somebody has an unexplained hagma. So management of D-lactate. Again, it's simple: hydration, renal replacement, reduce carbohydrate overload. Whether to give antibiotics, because one postulated hypothesis is it's because of bacterial overgrowth. Whether to give antibiotics is controversial. Sometimes patients need small intestinal transplant if it is because of intestinal failure. And next slide, please. And epinephrine, when somebody is on epinephrine infusion itself, that itself is a cause for lactate elevation, because the epinephrine, when it stimulates the beta 1 receptor, it will cause chronotropy and ionotropy. On the other hand, when it stimulates beta 2 receptors, not only causes bronchodilation, it will also cause lactate elevation because it is a metabolic fuel for the heart. So subtle levels of lactate elevation can occur just with epinephrine infusion. Somebody has lactate levels high with epinephrine infusion, but he maintains good urine output. Not to worry, just continue supportive care. Thank you.
I have a question. Can I ask?
Yeah, please, sir. Yes.
Yeah. So basically, we are looking at a changing demography of the population. We are finding that we will no longer see 40s and 50s, but we are looking at 60s and 70s individuals who got subnormal GFRs, and people who are on multiple drugs, including metformin and several other aspects in terms of development of lactic acidosis, especially with the pre-existing cardiac failure. For a lot of patients, they also have circulatory problems. So the diabetologist is no longer dealing with patients who have a simple and straightforward lactic acidosis anymore. So you have a problem of multiple etiologies, and simply going by an ABG, looking at the levels may not be always easy in terms of correction. And what are your comments on this kind of a complex presentation where you have multiple problems coexisting simultaneously?
I'm not an expert to comment about congenital causes or other hormonal causes leading to lactic acidosis, etc. But basically, what as an intensivist, how I look at lactic acidosis is, as such, it is an innocent molecule. As such, standalone, there is an underlying serious problem which leads to this deterioration, increasing lactic acid and worsening metabolic acidosis. So I would prefer to diagnose the cause for underlying cause for elevation and address it, rather than trying to remove the lactic acid alone. Let it be whatever. Let it be a underlying congestive cardiac failure, or let it be a HFrEF, or let it be drug-induced cause for lactic acidosis, etc. So in this context, just because there was a molecule a couple of decades before, I couldn't remember the name. It came to the market where they even tried in septic shock. The molecule was very effective in removing the lactic acid. Lactic acid production comes down. At the production level, it comes down, but the mortality didn't change. Mortality rate was still high because without addressing the underlying factors, if you try to remove the lactic acid alone, it won't solve the issue. That's one thing. Second, since you mentioned about metformin, again, the way I look at metformin and lactic acid association is, it is just a temporal association rather than a causal association. That's what I believe. And I think even penformin followed by metformin have been inadvertently blamed as a cause for lactic acidosis. I think now the current recommendations say only if the eGFR is less than 30, you withhold. metformin. Unless the eGFR is more than 30, I think you can continue metformin in this context. Apart from that, the management is going to be the same. I mean, the approach to lactic acid is going to be the same. Identify the primary cause, hydrate. Beyond a point, if metabolic acidosis is uncontrolled, do dialysis.
Yeah. So
Sorry if I
dialysis,
didn't answer your question fully.
yeah, no, sir. I mean, it's the presentation was extremely crisp, to the point, and you kind of hit the nail on the head. So I'm a nephrologist. So my concern is
I know, sir.
mostly
I know. Yeah.
I inherit a lot of patients who are kind of receiving multiple therapies at different institutions, and then often present with refractory shock. So that's a point of time that we are all asked to intervene. And lactic acidosis is not particularly amenable to dialysis. Dialysis is not a
Okay.
great treatment to treat lactic acidosis. And as you rightly said, the D-isomer version of lactic acidosis is definitely dialysis. It's not amenable to dialysis at all.
Oh,
What we can do something about is the L-lactic acidosis, the levoisomer, and even then, when you have multiple competing risks like circulatory shock, or patients who have developed severe septic shock or intracellular mitochondrial dysfunction secondary to sepsis and severe lactic acidosis, these patients do not respond at all to any form of intervention. And in that sense, your presentation makes very valid recommendations that you have to identify it early and you have to treat it aggressively, especially you have to identify the cause and address the cause much earlier than what is necessary. So, hydration and addressing hyperglycemia, and then switching over the metabolic problem to new metabolic state is probably the most important aspect when it comes to management of simple lactic acidosis as far as management is concerned. And lactic acidosis cannot be cured or cannot be controlled by dialysis. Dialysis is not the modality of choice. And bicarbonate therapy for lactic acidosis is hopeless, especially when the pH drops below less than 7.1. And you have severe lactic acidosis when you have more than 2 or more than 3, or some cases, some authors propose a cutoff of more than 4. It's usually a terminal event. Generally, you don't have much to offer for such patients. And that's why it is important to catch lactic acidosis much earlier and then identify the cause, not necessary, whether it's a type A or type B, and address the issue that will serve. For example, fenformin related metabolic acidosis is particularly amenable to dialysis. These patients can be saved. But other forms of metabolic acidosis, if they are missed, like ethylene glycol toxicity, for example, you're not likely to make any outcome. You're not change the outcome when the presentation is too late and when the pH drops below 6.9. And I would say 6.9 pH is probably not the point of intervention. You need to intervene when the pH drops below 7.1. And bicarbonate is not a great therapy for lactic acidosis. It's only for you to kind of tide over the crisis. There are several trials. For example, the BICARB trial in the ICU is one of which most of you might be familiar with. It clearly says there are only 3 indications where bicarbonate intravenous therapy is much useful. One is when you have AKI with hyperkalemia and acidosis, bicarbonate therapy is useful. And the second situation is in situations of drug toxicity where it is useful. But apart from these two circumstances, bicarbonate therapy is not largely useful. Even in post myocardial arrest resuscitation, bicarbonate is not favored as a therapy. So that's a consensus. But having said that, bicarbonate is one of the largely misused, or let's say used drug because the circumstances are desperate. We tend to give more bicarbonate when the pH is less than 7.1 and try to see some change happens. But unless we handle it earlier, so therefore the message which you have particularly conveyed, that you have to identify the cause earlier and deal with it much earlier, is very, very important, very apt. Thank you so much for a beautiful presentation, sir.
Yeah. As you rightly mentioned, just one more point I want to tell, 2 more points. As you rightly mentioned, we also use by another classical indication for IV bicarbonate in ICU is tricyclic, poisoning, where we titrate bicarbonate based on QRS interval. You have to keep giving bicarbonate infusion until the QRS narrows, because QRS widening is representative of TCA toxicity, tricyclic antidepressant. That's one thing. And off late, I'm sure some of you would have read this. Your capillary refill time, just a simple clinical examination. Capillary refill time. It's a very time-honored teaching at the bedside. keep looking at your nail bed reperfusion. You prick, just press your nail bed. Look at how much time the capillary takes to refill. This is as good as a lactate level, even in sick critically ill patients. CRT, capillary refill time, is as good as a lactate. So I want to just highlight this point. Even in resource limited settings where you cannot even get a lactate levels, just CRT, that will tell you whether you have adequately reperfused the tissues. Thank you, sir. Thanks a lot.
Absolutely, sir. This the point on CRT is particularly it's important. The clinical examination by the bedside is a lost art these days, and I hardly ever come across in critical care units, even in my own hospital, despite repeatedly telling residents and even the consultants to look at the capillary refill time. I mean, we don't expect them to do a passive leg raise, but at least doing a capillary refill time, it's not something which is very easy to inculcate, but it's an extremely useful test. Thank you for highlighting that.